Welcome to the next video, guys. It's been a long time that I didn't do any video. I was tied up with a lot of other things, but let's go ahead and continue our conversation about the treatment of chronic stable angina. And this is the part 3 of 5. And this part will include drugs with mortality benefits. Okay, so in chronic stable angina, these are the drugs that have been shown to have mortality benefit. The first one is aspirin. You can use a dose 75 to 162 per day. That's sufficient. There's no need to do 325 daily. If you keep doing 325 daily, it will increase the risk of bleeding and does not further reduce cardiovascular risk. So studies have been done, and it has been conclusively shown that a dose of aspirin 75 to 162 is good enough for the mortality benefit in chronic stable angina. For those patients who are intolerant to aspirin, you can do clopidogrel, 75 milligram per day. And I've written the trade names of a lot of drugs. I'm not going to say all the trade names, but they are there for your reference. If you're more familiar with trade names, you can look at them. If you're more familiar with generic names, you can just use the generic name. After aspirin, the second most important drug is the moderate to high intensity statin. And basically, whether you give moderate or high intensities actually depends upon how much the patient can tolerate the side effects of the drugs. So basically, the moral of the story is this. You can try putting the patients on high intensity statin, but there's a problem. If they have side effects, then a lot of patients don't want to take the drug, but that's really not the right thing to do because the statins have repeatedly been shown to have mortality benefit. So if you start a patient on a high intensity statin and the patient has side effects, please back off to moderate intensity. But try as much as you can to keep the patient on statin because of its mortality benefit. So the two most commonly used are atorvastatin and rosuvastatin. So I've written the doses here. For atorvastatin, the high intensity is 40 to 80, moderate intensity is 10 to 20. For rosuva, the high intensity is 20 to 40, and moderate intensity is 5 to 10. Now, if you've tried high intensity, you've tried moderate intensity, there's absolutely no way the patient can stay on it because of bad side effects, then you have to back off and you can choose niacin or some bile acid sequestrants like cholestyramine. However, please take into account that they are not going to be as beneficial as the statins. The third drug in the improved mortality group is the beta blockers. And the three most common ones that have been shown to have mortality benefits are carvedilol, metoprolol succinate, and bisoprolol. And the reason I didn't write down the dose is that the doses may need to be titrated based upon. So suppose you start the patient on a particular dose and the patient continues to have symptoms, then you're gonna increase the dose until you get to a level of dosing that the patient can be maintained in a stable condition. So the dose varies, and that's why I didn't put it down. Then the next group of drugs are ACE inhibitors. So if you use ACE inhibitors in the treatment of patients with chronic stable angina, you have to make sure that they have one of these underlying 4 conditions because that's the setting in which they were studied. So if the patient has hypertension or diabetes or chronic kidney disease or a left ventricular ejection fraction less than 40% and they have chronic stable angina, you should go ahead and use ACE inhibitors. And then for some reason, if the ACE inhibitors, the patients can't tolerate it because most likely the symptom they have is the cough. So then you can change to angiotensin receptor blockers, but the above 4 conditions still apply. So, and the reason I didn't put down any of the names of the drugs of ACE inhibitors or ARBs is that there is a lot of them. There's many drugs on the market, so you can take your pick. So these are the drugs that give mortality benefits in patients with chronic stable angina. There are a couple of things that I would like to highlight that I recommend that you should never do. And one of them is do not give postmenopausal women with chronic stable angina estrogen treatment to reduce the cardiovascular risk. It doesn't work and it has its own side effects. And also, a lot of patients come to me and they are talking about vitamin C, E, or beta carotene. Again, these vitamins, they really don't work. And so there's no reason to recommend any of these vitamins in patients with chronic stable angina. Thanks for watching the video, and if you like the video, please go ahead and subscribe to my channel. And in the next video, I'm gonna talk about drugs for chronic stable angina that treat the symptoms but do not offer mortality benefits. Thanks for watching this video. Bye.